Welcome. Today we will be addressing some community health needs through the use of a community health assessment for the area of East Harlem. Before we get started, we want to get an idea of the history of the area and the key demographics that make up the East Harlem area. In the 1800s, there was a movement basically just to escape some of the overcrowding in the more heavily populated areas of the New York City, New York County area. During the early 1900s, it was primarily an immigrant community with more of a diversified group of people, and it wasn't until like the mid 1900s where we started to see a push for a higher number of Hispanic communities, mainly from Puerto Rico, following World War II. The area's been surnamed or nicknamed Spanish Harlem. It's mostly a 50% Hispanic community. The other parts of the community, 31% African American, another 12% is Caucasian, Asian, and other races make up the other 10%. So it's a loosely diversified area, and now we're starting to see a little bit of another shift as kind of on the outside of that area. There's been some what we call gentrification, where more developments are getting renovated and the higher prices are starting to occur in those areas. But the area still remains highly a minority community. So we'll just give you an idea of what type of demographics we're seeing here, and just based on that, you can get an idea of what type of health issues you might be seeing. So the community health model that we'll be using to address the community health needs within the East Harlem community is mobilizing action through planning and partnerships. This is a 6-phase model that includes organizing, visioning, assessment, addressing strategic issues, developing goals and strategies, and placing them into action. It's a very easy model to understand. In comparison to other models out there, we felt that this was the better suited model to address our needs. And we'll be getting into each phase of these as we move along. So as you can see here, this is a design of like a flow chart for how we go about using this mobilizing action through planning and partnerships. I like to call it my roadmap. But as we move along, we got each step of the phase, 6 phases, and then we have a little adaptation, and we loop back around into that second phase, which is the visioning phase. And you'll see why as we move along into the next few slides. So the first phase, we're going to develop our team. We have the MAP committee, which is formed from members of like your local health community, mostly administrators, like administrative personnel rather. You either have public health officials that are within the area, maybe political people who have an idea of what's going on in the community, but mostly you want them to have some type of understanding of what's going on. But they need to be people who have the ability and experience to put things into action. After that, you have your core support team. This is going to be mostly health professionals like doctors, nurses, nurse practitioners, people who work within the community that can tell us, what they see on a daily basis and what, what's been effective, and what we really want is people who've been working within this community for a long time. Designated community members or volunteers. These are people who are within the community, who've lived there for a while, they know what's going on, they know what, word of mouth, what people are going through within their local neighborhoods, or family members, or what have you. But we really we'll take you would take volunteers here, but you also really want to look at people who actually have been within the community for a while and know what's going on. So when you look at the strategic issues, that you have several things that you have to consider. You have to consider whether or not a certain priority that you've identified has the ability to be improved. But you also have to consider whether or not you have intersecting issues. One of the things that intersects all throughout this process of data collection, if you get better data you can have the ability to give better results for the specific populations. If you have 50-50 for all your issues, then you don't really need better data. But if you have a population that is higher, say in gender demographics or age demographics, then you really need to address issues that are specific to them, and you can't do that without better data collection. So we're really thinking that that's the main focus. We don't want it to be the number one focus, because nothing will get addressed if you don't actually address a health issue. So another one of the things that we looked at through our priority list is that mental health care may improve substance abuse rates, but it also may be the other way around. But if you go to address one of those issues, you don't necessarily have to address both of them. But you have to decide which one of those is your highest priority, and you will likely see improvements in both by addressing one of them. It can be a good cost saving measure. For our asthma issue, which is probably one of the cheapest ones that we could address, because giving out literature or providing media to help people understand how to manage it is probably an easier way than providing more mental health centers and substance abuse clinics and whatever. But we found that improving asthma management in children can eventually improve the asthma management or the adult hospitalization rates for asthma. So we really should want to address the parent population with our program in order to improve the management. And as the management improves in the children, you'll eventually see adult hospitalization rates. That doesn't mean that adult hospitalization rates aren't important. It just means that we have a better chance of improving both if we address children first. If we have the resources, we can address both. If we don't, we want to address children first, and then you'll see those numbers increase. And also by providing media that's specific to parents, you might have plenty of parents that have asthma as well, and that might also improve the adult hospitalization rates without actually targeting just adults. So moving on to goals and strategies, we want to build a collaborative effort with local health centers and hospitals for improved data collection. And we want them to put the data together. We want them to put the demographics with the data and put it all together so that we can see a visual representation of that data and know who it is that who has the health needs. Then we can address those issues. But we also want to include the broad community involvement in that. Get their fellow community members to go and see their primary care, go to free clinics, or if they don't have insurance, or go to just get out there and report when there's ill as best they can. Some people can't. We understand that, but we want to know who those people are so we can address their needs. And then we also want to improve the resources available for the community. We want to make sure that for our asthma issue that people know how to manage it properly. People know when they're at risk. there's certain times when you're at risk, so you need to make sure you have your inhaler, you need to make sure your prescription's filled, and that you're ready so that you don't have to be running to an emergency room to handle something that you could have handled yourself. And these are just some of the things that we've looked at throughout this assessment, and we think that are good goals and strategies to address. So putting it all into action, we're going to build a network within the team and the outside resources to improve this data collection. We're going to get all this data together and really address some of the needs within the community that we can't otherwise address. We can know what our need is, but without that data striation, where we know what age group you're in, we know what gender you are, we know what race or ethnicity you are, and what your health issues are, we don't know how to adequately address those needs. If it's a program that's going to be based on those demographics, we can better address them. But if we don't know what those demographics are, we can't really target those. We just target what we do know. And what we do know is there's a need for better asthma management, so we're addressing that. But throughout the process, we'll also be collecting data, and we're going to cycle back to the visioning phase and reassess the data and find out what other needs might need to be addressed. So in summary, we went through and described the community health needs of the Eastern Harlem community. We found that they were underrepresented in data collection, and we just wanted to see a little bit better data, or a lot better data, that tells us a little bit more about who is affected by community health needs. We described some of the key issues, which were asthma, mental health, substance abuse, but we really wanted to see that data improve, but at the same time address some of these needs. So we prioritized, and then we designed a model that would loop back around. The model that we used was mobilizing action through planning and partnerships, and we did a little bit of adaptation that allowed it to continuously loop back around because of the data that we'll be collecting throughout the process. This helps us better serve the needs of this community. I hope you were able to learn something from this presentation, and thank you for your time.